Hello everyone, my name is Eric. I'm an emergency physician at the Landspitali in Iceland, and I would like to tell you about why I love the groin access during my resuscitations. So over the years, I've come to appreciate that having good IV access is just paramount during a resuscitation. And when patients are in shock and they're clamped, IV access can be challenging, which puts us in a bad place because we want to have blood tests, we want to give them fluids and pressors. I would like to say that one of the things that triggered me doing this is Josh Farkas from Pulmcrit, who dubbed the expression the dirty double. I don't want to misquote him on it, and you should read his blog, but the idea is that when a patient is crashing, you might not have time to do a fully sterile technique for double access the femoral vein and artery. You should do your best at it to be sterile, but sometimes we might not have the time, and as long as you come clean about it, so the receiving team can follow up on it. So in this movie, I'm going to expand a bit on that thought. I go over the kits that we have at our shop, the anatomy. I won't go over the technique because there's already some very good movies on the internet. But again, kudos to Dr. Farkas on it. So over the years, I've been appreciating more and more having art lines during resuscitation. They give us a lot of information about the pulse, the pressure, the fluctuation over time. And also I find it makes us act quicker on it. So instead of having measured a BP cuff every minute and where we're kind of like always trailing behind, now we're seeing the pressure in real time. In the ER, we would put an A-line regularly for septic shock or shock in general, severe traumas, severe GI bleeds, and just other sick patients. One area that I use it more and more is in cardiac arrest. I use it for many reasons. During post-check, we can see if there's any BP that is just so faint that we cannot palpate, aka pseudo-PEA. And also, where I really like it is during a RUSC. So I like having an art line, so when we get a RUSC, we can just titrate the pressure better. Speaking of which, during cardiac arrest, though having a radial art line is very difficult. I've seen people trying to put a radial art line during CPR and it fell. No surprises here. So one of the anatomical area we could go instead is the femoral. And the rationale also is that when the patient is just at the sickest, they're basically clamped, their cardiac output is low, we're in a low flow state. So the femoral area, artery just makes more sense. If you want to talk about the groin, it really starts by having a good understanding of the anatomy. It all starts with the femoral triangle, and I didn't know it's also called the Scarpa triangle. And this is really where we want to get our access. Imagine this as a triangle with a 90 degrees angle. The upper limit, the oblique limit is going to be the inguinal ligament. The lateral line is going to be the sartorius muscle, and the medial is going to be the adductor longus. This triangle is significant because in slight flexion, abduction, and external rotation, it makes a small depression, a small triangle, and this is where we want to cannulate. And this is for this exact reason that when we frog leg the patient a bit, it's a bit easier to cannulate the patient. There are a few ways of finding our area of interest. First is anatomically, and then the other way is with ultrasound. The first one would be to find the symphysis pubis, and then the ASIS, the anterior superior iliac spine, and then you draw an imaginary line between the two, and this is where it gives you the inguinal ligament. Once you have that line in mind, you want to try to locate the middle point, and this is where you should find your femoral artery. At this point, you should grab the ultrasound probe, confirm it, okay, and identify the structures. One of the reasons I still palpate is that I find that if I just use the ultrasound probe from the get-go, I have a tendency to be a bit lower, but maybe that's just me. Once you find your area of interest with the ultrasound, you have to think about IVAN. So what is there? It's the mnemonic IVAN, anterior, vein, artery, and nerve. So IVAN, anterior, vein, artery, and nerve. So the vein should be compressible with pressure, but not the artery. But keep in mind that during cardiac arrest, specifically during CPR, the arterial flow is low and the venous return is congested. So you might be tricked looking at the femoral vein. You see it's big and you think this is the artery, but keep in mind just because the venous return is congested. So in CPR, it's really easy to confuse them if you don't remember this IVAN. Once you know where you are at the right spot, midpoint in the inguinal ligament, you have identified the anatomy with ultrasound, your area of interest. Now you want to go 2 to 3 centimeter below the inguinal ligament, and this is going to be where your sweet spot is going to be for a cannulation. You really want to find the sweet spot which is above the bifurcations of the vein and artery, but also below the inguinal ligament. Once you know you're at the right spot, midpoint in the inguinal ligament, you've identified the anatomy with ultrasound, then your area of interest for cannulation is about 2 to 3 centimeters below the inguinal ligament. So this is the sweet spot above the bifurcations of the vein and artery, but also below the inguinal ligament. You don't want to be too high because otherwise if you backstab and there's a bleeding, you're now in the abdominal and retroperitoneal area, and if there's any bleeding, it's a non-compressible area. Just to keep in mind, when we're aiming for about 3 centimeters below the inguinal ligament, you have to think about trigonometry. Obviously, these vessels are a few centimeters below the skin. It might be a bit more if the person has a larger body habitus. So when we're going to aim for the vessel, we want to make sure we're a few centimeters lower, entering at a 45-degree angle. And this is where I think the ultrasound helps us even more, is that you can also measure how deep the vessels are and then kind of like imagine the path of your needle and how deep you should go. I won't talk too much about the technique here. There's already good movies on the internet already. Now I want to go over the kits that we have in our ER, starting with the CVK. So we've decided to have two kinds of CVK in our ER. One is a 1 lumen, another one is a 3 lumen. The 1 lumen, some people might think it's stupid, but actually I think I really like it. It goes quickly. There's only one line, 1 lumen. We don't need to flush the other lines, and also the diameter is a bit larger, so we can give larger amount of fluid or blood if needed. And then worst case worse, if we needed 3 lumen, then we can just thread back a wire in it and convert it to a 3 lumen CVK. Moving on into our femoral arterial line kit. This has been a very game changer in the ER. We bought this kit about 1 to 2 years ago. Before that, we used to have a Secalon, which I'm going to talk about it later. But now this is a ultrasound opaque needle, insertion needle, and then we thread a Seldinger wire, and then we just convert it to a I think it's a 16 gauge arterial line, and this has been basically a game changer. It makes things so much easier. It doesn't take much more time. Actually, I think we save more time because we just see better the ultrasound, and we mess around a bit less. And this has made some of our colleagues in the ICU a bit jealous of our kit. Let's talk about complication now, because there are some. The two biggest are bleeding and infection. We can also damage the nerve during this procedure, and on the longer term, there's also risks of DVT. But I'm going to talk about more the immediate complications. The most obvious one is probably the bleeding, specifically for femoral arteries. It's a big vessel. For those interested, I'm going to put an article in the show note which goes over all the complications possible with femoral artery cannulation. Bleeding risks are mostly hematomas. I mean, we can cut an artery, we can dissect it, we can backwall it. There can be an AV fistula also from the femoral artery to the femoral vein. And also one of the catastrophic bleeding we can have is in the retroperitoneal cavity. If you go a bit too high and then you backstab the vessel, you do a backwall puncture, there's a bleeding, you're now in a non-compressible cavity, and this you can be in a bit of trouble. So this is one of the reasons actually we want to cannulate in that sweet spot above the bifurcation and below the inguinal ligament, is that if it bleeds, we can compress, and the artery is actually just against the femoral head, so you now have a compressible bleeding. Infection rate for A lines, femoral lines have higher rate of of infection compared to radial lines. We have studies about it, okay? Vast majority of these studies had maximal barrier precaution, and some of them had a bit of just sterile gloves, but still, all in all, there is a higher risk of infection, so we have to admit it. Speaking about infection rate for CVK now, interestingly, historically, femoral vein has been associated with higher risk of infection, catheter-related bloodstream infection, but newer literature shows that this might have changed, and now that we have better sterile technique, we have checklists, we use the ultrasound, chlorhexidine impregnated dressing, the infection rate from the femoral versus the IJ is actually quite similar, and both of them though have a significant more infection rate than subclavian. So actually, if you want to use infection rate as an argument, you should actually go subclavian. Another study was talking about failure rate. Interesting study done in the ER actually. It shows that radial art lines have much higher failure rate compared to femoral lines. They had femoral lines had an absolute reduction rate of 20%, and the failure rate was defined as either accidentally removal of the line, a blockage, or inaccurate reading, or some local tissue problems. So this might be something more for ICU colleagues who are going to follow the patient for a few days, but still, femoral art lines had much less failure rate than radial lines, interestingly. Also, shock, specifically septic shock, patients on vasopressor, femoral and radial art lines correlate their values, but the radial art line actually underestimates the MAP in these patients, and this effect was amplified for patients in higher dose of noradrenaline. Now the question is if this physiological difference is clinically significant, but still it puts the patient at risk of escalating treatment, increasing pressures, or just adding another agent because but the patient does not really need it. So all in all, the rationale to use a femoral vein and artery double setup is that it's a easy body access, and it could represent a better physiology of the patient during shock and during decreased cardiac output patients. And in a very sick patient, this might reflect more the real physiology of the patient being closer to the central pressure, the aorta. So where I would personally favor a femoral line, that would be in cardiac arrest, also in RUSC, in shock in general. If we have a difficulty accessing the patient for many reasons, also in major trauma. And one thing that is interesting is that one of the reasons I also favor it is for geographical, I would say, reason, and also ergonomical reason. So where I work, we usually call ICU during resus, and historically they stand at the head of the bed. And me personally, as the leader, the team leader, I usually stand more on the side of the patient, so the femoral area is closer to me. So I don't have access to the neck or the upper chest because of many reasons. So I would tend to favor the groin because this is where I usually stand. Just a closure note on the Secolon, which are these like long catheter over the needle that we have in the ED. I don't think I've seen it. I don't remember seeing it in North America, but that's something that they use quite a lot, I think, in Europe. And my opinion is that nowadays in 2022, we should probably stay away from it as much as possible. I've used it a lot, and I have to say that they are not really ultrasound opaque. It's almost like a blind stab. We don't really see the tip of the needle. The only thing we see is just like the tissue moving around it. And also it's not a Seldinger technique. So I mean, we still have it just in case, but nowadays with ultrasound and better technique and also better needles, which are ultrasound opaque, I think we should favor the kit that I presented there earlier. So, all right, everyone, just to wrap up, cannulating the groin during a resus trauma cardiac arrest is just a great tool for us in the ED. It's definitely something our residents should learn and our consultant. It starts by knowing well the anatomy and understanding well the patient population that we should use it on. Keep in mind that these procedures, we might put in a rush, we might not be completely sterile, so we just have to make sure that we chart it, and then also we just hand it over to the ICU team, which are usually going to receive our patient. And please use the ultrasound. And we didn't cover the technique, but there's some, plenty of great online movies about it, how to use the Seldinger technique. So hopefully you learned something, and please reach out for me if you have any comments or questions. And this is Eric, and I'm saying bless.